Hello, it's really good to be with you, and thank you so much to Luigi, my dear friend, and to all of you at the Italian Psychiatric Society for including me at this meeting. I wish I could be with you in person. Today, we'll be talking about psychosomatic medicine and CL psychiatry, consultation liaison psychiatry in the United States. As I talk about this now, here in the United States, we're going through lots with our elections and changes. And so it seems reasonable to me that just like we're having political issues, we've had some political issues with the terminology in our field. I'm a CL psychiatrist, consultation liaison psychiatrist, and also a psych oncologist here at the University of Michigan, which is in Ann Arbor, Michigan. And I've also been past president of the American Psychiatric Association. And the reason this topic is interesting and important, not only for the field, but when I was president of the APA and a few years before that, I helped in trying to get this subspecialty recognized by our American Board of Psychiatry and Neurology. So it's of some importance to me personally, and I thought I might share with you some of the history and how we got to this point here in the United States. So some of my disclosures are I've been an author or a reviewer or an editor for some of these publishing companies, many of which I've done with Luigi. So some of the objectives for this presentation will be to give some of the history and some of the issues about the subspecialty, which in the United States, we have a 4-year residency program, psychiatry residency program after 4 years of medical school, and then a year of subspecialization in consultation liaison psychiatry. I'll talk about some of the models and some of the issues currently for our field of consultation liaison psychiatry. So as you well know, this dichotomy between the brain, mind, and body has been with us for centuries. And so, so this is just one example of this dichotomy and separation of the soul from the body. The history of consultation liaison psychiatry or psychosomatics or psychosomatic medicine really has a European footing. So this term psychosomatics was used in the early 1800s by Johann Heinroth in Germany, and then continued by a Harvard physiologist, Walter Buchanan, talking about stress and adaptation, followed by, in the 1920s, Viennese psychoanalyst Felix Deutsch talked about psychosomatic medicine. So we're using these terms, over 200 years ago. In the 1930s, Edward Billings at the University of Colorado started using the term liaison psychiatry, and then back to Europe again in the 1940s with Franz Alexander talking about psychosomatic medicine. So many of us in the United States think about Franz Alexander as sort of the father of psychosomatic medicine. And he, of course, talked about some of the major medical conditions, such as peptic ulcer, which we know now is a infectious disease-based problem. But many of these it was thought, a psychosomatic basis to it. This was in the 1940s, 1950s, and that's sort of where we begin the topic of the history of CL psychiatry or psychosomatic medicine. Flanders Dunbar at Columbia sort of was the first editor of the journal Psychosomatic Medicine, which continues today. And Hans Selye from Vienna talked about the importance of the hypothalamic pituitary axis, the HPA axis, activating stress, or really being an important aspect. And we continued that later, thinking about depression and the HPA axis. And then Peter Sipnios, who was from Greece, and John Nemeyer, who was at Harvard, started using the term alexithymia, sort of the issues about brain and emotions and the words for that. Friedman and Rossenman talked about the type A behavior and coronary artery disease and stress. And then Herb Benson in the 1970s from Harvard helped us understand the relaxation response. George Engel really was the father with John Romano at the University of Rochester with the biopsychosocial model, and actually created the liaison service at the University of Rochester, where many of the psychiatrists in the Department of Psychiatry at the University of Rochester were assigned to work with different services at the inpatient services, like the CCU or coronary care unit or the geriatric unit or the gastrointestinal unit, as liaison psychiatrists. And George Engel created this liaison service really based on this Monica project. And you might remember it was an infant with congenital blockage of the esophagus, and they monitored the feedings and saw that there was some associated related to her moods. George Engel was very he was a twin, and he had a twin brother, but he was very articulate about psychiatry's responsibilities in medicine, and wrote this editorial in the American Journal of Psychiatry when it looked like psychiatry might give away its internship. And so we used to have a medical internship in the first year, and we changed it to more of an internship that would help psychiatrists. So we added family medicine and neurology, and half of it is now psychiatry. So he was very interested in our training and how we were training interns and residents, and how we would continue to help care for patients with chronic medical conditions. But in the United States, the psychosomatic medicine terminology really morphed into this biopsychosocial, and then we added economic version of psychosomatic medicine. And it was really based on George Engel, who was a psychoanalyst as well as an internist. Continuing the history, in the 1970s, we started using the term consultation liaison psychiatry, mostly in the hospital setting. And in the 1990s, we tried to have, and I was part of that effort, to have consultation liaison recognized by the U.S. American Board of Psychiatry and Neurology, and we were turned down for that designation. Following that, Wayne Caton at the University of Washington, who unfortunately passed away a few years ago, developed this collaborative care model, which is not to be confused with psychosomatic medicine. But in 2003, we were able to officially become a subspecialty of psychiatry, and we had to use the term psychosomatic medicine, or PM. And the idea was that we would be taking care of the complex medically ill. And then in 2018, we rebranded this term because psychosomatic medicine really didn't work here in the United States from 2003 on. And we became the subspecialty of consultation liaison psychiatry. And our home is the Academy of Consultation Liaison Psychiatry, ACLP. And I just want to mention that the organization, Psychosomatic Medicine, that was formed by Flanders Dunbar and others, became the American Psychosomatic Society and kept their journal. So we have two main organizations here in the United States. And some say the ACLP is more for psychiatrists, and the APS has psychiatrists, but also others in it, such as social workers, psychologists, and others, as well as psychiatrists. So what's in a name? So psychosomatic medicine, the ABPN, the American Board of Psychiatry, turned it down. They said that why CL didn't work, consultation liaison, because liaison, other doctors do it. Cardiologists provide liaison, they provide consultations. Some said at the board that it had liaison had a sexualized connotation. That was actually one of the statements. And then when we did it, when we tried the second time, some people said, why don't you just call it psychosomatic? So we really had problems with the terminology, and form follows function. So we were really quite worried about how this term to the public and to us and to other doctors would work. So we tried a number of terms, as you can see: consultation psychiatry, consultation liaison psychiatry. Some people have called it medical psychiatry. Some people called it collaborative care, integrated care, behavioral care, holistic medicine. So, you know, we've had this problem for the last at least 30 years. Psychosomatic, what are the definitions? And you can see that many people tried to come up with this, but we were having problems in addition because some people thought it was alternative medicine. But I think you and Italy and other countries and Germany still continue to use this term psychosomatic medicine. And you know, why are we having these problems across different continents? And do we have a specific term that we're all using? And why is there a problem? I wish I was there in person to have this discussion with you. But this is the journal that Dr. Dunbar's started, called Psychosomatic Medicine, as you can see. And our, you know, Giovanni Fava, who I know is very well known to you, put this paper out in 2010 saying that psychosomatic medicine is a field and it's not a synonym for consultation liaison psychiatry. So I recommend that to you if you're more interested in this topic. And of course, Dr. Fava is at the University of Bologna. This is just an example in 2017 that Larry Faulkner, who was president and CEO of the American Board of Psychiatry, changed the name of our specialty from psychosomatic medicine to consultation liaison psychiatry. So, so as we think of it, probably consultation liaison psychiatry is the clinical derivative of psychosomatics, and except probably in some countries in Europe where it's a unique specialty. And why was this name changed in 2018? Well, many people thought psychosomatic medicine was problematic. We thought it had a pejorative connotation. Many patients thought of it as a negative. We were having a recruitment problem because we thought that, you know, into the specialty after residency, people did not know, residents did not know what this term meant. Clinicians didn't, academic departments didn't. It was controversial from the very beginning. And in fact, many of us never really used it. We just kept using it at CL, consultation liaison. We did a survey of this and we did the name change in 2018. But whatever you call it, consultation liaison psychiatry in the United States, you know, we think there are some psychological presentations. We had this problem with organic disease versus non-organic disease. And Lepowski, even in 1967, talked about these issues about consultation liaison psychiatry. The liaison part of it has to do with communication and cooperation and a close working relationship. And even Ed Billings at the University of Colorado wrote about this, but Engel popularized this. And Dr. Engel, talked about the liaison at the University of Rochester, bringing it from a Latin derivation, and that liaison is important in all fields of medicine, just not necessarily in psychiatry, but it's important in education, care, and research. The models of consultation liaison psychiatry are traditional now, that departments can ask for a consultation upon request. So we call that a reactive position. As you probably have in Italy, like in the United States, many patients' care is moving to the outpatient setting, the ambulatory setting. So at Hopkins, Johns Hopkins, Yale, and at the University of Rochester, they are moving consultation liaison psychiatry from a reactive position to a proactive position. And which means that doctors are making rounds, looking at cases and deciding and thinking about patients who may need a consultation or psychiatric care very early on in both the inpatient services as well as outpatient care, and not waiting for the coronary care unit doctors or the gastroenterology doctors to have to think about making a referral or asking for a consultation. But psychiatrists are at the forefront of setting up a consultation the very beginning of a hospitalization and outpatient treatment. And some are doing these hybrid models where it's both a reactive as well as a proactive type of consultation, again, both in the inpatient and outpatient settings, but it's a little bit trickier in the outpatient settings. And we are looking at complex comorbid psychiatric and medical conditions. An example might be lupus, having a patient having lupus coming in with a flare for lupus, patients who are coming in with neurocognitive problems, functional problems such as a gastrointestinal problem, and psychiatric disorders secondary to medical conditions. And the function of the psychiatric consultation may be for the patient, but also a way to help the doctor who's in charge of the patient in the inpatient unit or outpatient service better help address the mental health needs of the patient and the family. And again, the overriding needs and concerns always are the patient's well-being. So the essential tasks of a consultation liaison assessment would be to provide and develop a reasonable treatment and management plan, to remove the impediments to medical care, to bring a fresh perspective to the clinical dilemma that's being posed. Sometimes there are arguments going on in the clinical team or with the patient or family. So to help identify and articulate what those issues are, and then educate the clinical team about what might be going on for the patient to help bridge the inpatient to the outpatient or outpatient to inpatient care, and whether there are some neuropsychological needs that are not being addressed and could be better addressed. So, in the United States, really, it's a shift now from the inpatient to the outpatient care of the patient. And then with that, how do we deliver consultation liaison services to that patient and team? These are some of the types of care that psychiatrists are usually called on for inpatient services, such as delirium or transplant care, liver transplant, bone marrow transplant. Substance use disorders is a major issue for us, and we have our own and different substance use disorder team, different than the consultation liaison psychiatry team. The physicians and clinicians who run the substance use disorder are addiction trained and often have psychologists and social workers attached to that as well. And in the ambulatory setting, we're doing more and more consultative and collaborative work with our primary care clinics and the surgical and medical subspecialties such as oncology, obstetrics, gynecology, neurology, and transplant. So who will be the consultation psychiatrists in the future, and will they even be physicians? Here we have many physician extenders, we call them mid-levels, and they could be nurse practitioners, PAs, physician extenders, social workers, case managers, and peer counselors. Sometimes they're not even clinicians per se, but they help in trying to help patients navigate the system. And we see that in various disorders such as cancer and cardiac disease. So questions for the future: what are our roles if we have case managers versus psychiatric consultants? Are we there for the diagnosis and treatment, or do we sign off to case managers, physician assistants, for example? And how do we best collaborate and coordinate our care? What is the cost savings to using physician extenders and social workers and nurses? And is it really just about cost savings? What about the quality of care? We're trying to do, research in this area and educating our residents for this future. Some training directors have called for trying to decrease the length of time that residents are in training and then using the fourth year for subspecialty training, such as in geriatrics and consultation liaison and addiction. And others want to protect that fourth year and only use the fifth year for subspecialty training. Right now, the focus of consultation liaison is on populations, not necessarily on the individual patient necessarily. And so we're trying to define the role of psychiatrists and psychologists, and using technology seems the way forward. We're trying to use AI, artificial intelligence, to try to help us better understand the profiles of patients coming in, and to do this proactive consultation to really get in there very quickly to help patients and clinicians and families get that psychiatric attention and not wait for the last day of the hospitalization. The same thing in the outpatient service. And we're trying to use this type of system so that it's cheaper and saves time and days in the hospital, as well as in the outpatient setting as well. And seemingly that patients and clinicians seem to appreciate this kind of service, even doing telehealth, even when the patients are in the hospital delivering psychiatric care. So will this help the current psychiatric shortage? Will it improve patient safety and appreciation for psychiatry in the future? And these are unknowns, but we're trying to study this. And as we said before, we're really trying to actively help patients with this, and trying to look at length of stay and support for different services on the inpatient as well as outpatient arenas, trying to use this proactive psychiatric consultation method. We are trying to measure how we're doing with this and how patients are doing. Other services have these ways to measure care, and we're trying to implement that on the inpatient as well as the outpatient service as well, in terms of how the depression is doing, how the anxiety is doing, how delirium is doing, both in the inpatient and outpatient settings. when we see patients in the consultation liaison services. This is our, this has been our journal, Psychosomatics, the Journal of Consultation Liaison Psychiatry, on the Academy of Consultation Liaison Psychiatry, where we in the Academy are trying to inspire, develop, educate, and nurture the CL psychiatry community and advocate for our subspecialty, train those for the future, both psychiatrists as well as non-psychiatrists, PAs, nurse practitioners, social workers, and how to anticipate and support the growth and priorities of our subspecialty. How can we learn from each other, whether we call it psychosomatic medicine or consultation liaison psychiatry? How do we evolve this subspecialty? How do we integrate and weave what we're trying to do into general care and subspecialty care, and collaborate with our medical and surgical partners? And how do we study what we're doing to improve this so that we continue to optimize what we're doing and provide quality care and safe care? So thank you very much. I appreciate you all, and thank you to Dr. Luigi Grassi for our friendship and our collaboration for so many years. Thank you to the Italian Psychiatric Society. I really appreciate being with you. Thank you.